Welcome to my presentation on the basic principles of nuclear medicine. My name is Julia Brosch Lenz and I'm a medical physicist working at the Institute of Nuclear Medicine. This presentation is aiming at providing you an introduction to the general topic and questions of nuclear medicine. I have nothing to disclose. So nowadays we would ask ChatGPT, what is nuclear medicine or what is radiopharmaceuticals? And ChatGPT would answer that nuclear medicine involves the use of radiopharmaceuticals, which are radioactive compounds designed to target specific tissues or organs in the body. These radiopharmaceuticals emit radiation, which is detected by imaging technologies like SPECT or PET for diagnosis, or is used therapeutically to destroy diseased cells. The procedures are carefully controlled to minimize radiation exposure, making them safe and effective for diagnosing and treating various conditions. So important here, you already hear it's for diagnosis and for therapy, but it's not only about radiopharmaceuticals. So radiopharmaceuticals is, as the name suggests, a pharmaceutical, so something which we can administer to the patient's body. However, I personally would add the following. I would say there's in addition radioembolization, which is a nuclear medicine treatment that involves injecting radioactive microspheres into the arteries supplying tumors, particularly in the liver. This localized radiation therapy targets cancerous cells while minimizing damage to surrounding healthy tissue. So important different here, we have something radioactive again, but it's a microspheres. So from the legislation, this would be considered a medical product, while this upper part here is considered a pharmaceutical. So what is nuclear medicine? Well, we need to think of radionuclides and isotopes, of course of radioactive decay, and we will talk about the concept of radiopharmaceuticals. And very important is the applications. Applications we can have diagnostics and therapy. But luckily for therapy, we sometimes can combine that with imaging. So there is PET and SPECT imaging. And what you can see here on the left is an exemplary patient who got administered a radiopharmaceutical, and you see everything that is brightening up. That is where the radioactivity is in the patient's body. So you can see that patient suffers from heavily metastasization into the whole skeleton. So every single bone here that shows uptake is infiltrated by cancer. However, you also see how healthy organs such as the kidneys, the spleen and the liver are showing uptake, which is the normal route of excretion of radiopharmaceuticals. With a little snapshot of history. Already back in 1941, Saul Hertz firstly administered iodine-131 or 130 for the therapy of thyroid hyperthyroidism. Then in the late 1950s, the gamma camera got invented, and in 1971, only then, iodine-131 got approved for benign thyroid diseases and thyroid cancer treatment. And here, I would say dosimetry is somewhat routine in the clinics as well. In the late 1970s is when the first PET imaging was performed, but only until 2018 is when nuclear medicine is experiencing a revival. Revival in the terms that lutetium dotatate therapy got approved for mid-gut neuroendocrine tumors. And neuroendocrine tumors are somewhat rare disease, and in the advanced stages there's nothing you can do. And this therapy is so effective that it got approved. However, it got approved without dosimetry. Similarly, in 2022, lutetium PSMA, another radiopharmaceutical, got approved for the advanced prostate cancer. Unfortunately, again, without any dosimetry. Now, let's talk about the Diagnostics principle for a moment. What you see here, and I call that a little Pac-Man, like in the game Pac-Man, that should represent a receptor on, let's say, a cancer cell. And depending on the cancer cell, this receptor is unique. And with that, you can differentiate between different forms of cancer, but also between healthy cells and cancer cells. On the other hand, you need to have a peptide or antigen. And what you see here is that the receptor and the counterpart have to directly fit into each other to enable the binding. So what happens during nuclear medicine is that we have a certain target on a cell that we would like to image or that we would like to treat with radiation. We design biochemically the exact counterpart. Again, it could be a peptide, an antigen, a small molecule. And to this we attach any radioisotope. A very common radioisotope or radionuclide in nuclear medicine is gallium-68. Gallium-68 emits positrons, and when they annihilate, they emit the annihilation radiation, which we can subsequently image outside the patient's body, and with that get an experience or an idea about the distribution of that radiopharmaceutical. So the right part here is being called the radiopharmaceutical in the patient's body. And since we know it's only targeting cancer cells or other cells and diseases of specific interest, we know that this is where the disease is. So this is the diagnostic part. However, we can just exchange that. So you see on the left side, nothing has changed. Even the peptide, the exact counterpart, is the same. But here the radionuclide has changed. So for therapeutic application, we use mainly beta minus emitter or alpha emitter. You're gonna hear more in the subsequent lectures on that. But importantly is lutetium-177 is a very, very prominent radionuclide, which emits beta minus for the therapeutic effect, but it also emits photons, and photons again we can image outside the patient's body and get an idea where our therapeutic radiopharmaceutical is distributed in the patient over time. So here for most of the therapy applications we can do imaging. However, the way of administration in nuclear medicine depends on the disease and the radiopharmaceutical. So no patient in nuclear medicine shows up and we have no idea what's going on. We are not like an emergency room. What we need is already an idea that that patient could suffer from cancer, so we perform staging, or we need an idea of which cancer it could be, such that we administer the correct radiopharmaceutical to find the extent of the disease. There are different ways of administration. We can have an intraarterial injection, and most commonly the intravenous injection. We can also inject via a catheter, for example for the liver radioembolization. That catheter needs to be placed in an angiography administration. We can also have an oral administration of a pill or a liquid. A cavity administration, for example after a brain tumor into the cavity in the brain, you could administer a radiopharmaceutical, but that is still under phase 1 and phase 2 clinical trials. And lastly, there's the way of inhalation of, for example, radioactive gas. As an example, we can just inject intravenously into a needle that is placed our radiopharmaceutical. For the imaging. Imaging depends, of course, on the radioisotope. The gamma camera is used for planar imaging. And the way it works is that we have the patient who got administered the radiopharmaceutical before, and then we have 1 up to 3 detectors, and each detector is a gamma camera by itself, is positioned before or behind the patient at a certain distance and then performing imaging. But we can also have single photon emission computed tomography, SPECT imaging. So you see it's exactly the same image like before, but here the detector heads rotate around the patient's body and therefore acquire views, so-called views around the patient over 360 degrees, and we can reconstruct the three-dimensional distribution of the radiopharmaceutical. Another imaging device very common in nuclear medicine is the positron emission tomography scanner, PET scanner. Here, if we have a location where the positron emitted by the radionuclide in the patient's body recombines with an electron, so it annihilates, it emits the 511 kV annihilation radiation, which is then detected by the PET detectors oppositely. Important to note, this whole ring here consists of detectors. So opposite to the gamma camera, where you have 1 up to 3 detector heads, which can be static or rotating around the patient, Here we have a full ring of detectors around the patient measuring the so-called line of response, here in yellow, to form a three-dimensional image of the radioactivity distribution in the patient over time. As a quick example, I would like to show you the lutetium-177 PSMA therapy. PSMA therapy is for the advanced prostate cancer. And what you see here in the upper row is SPECT-CT imaging, and on the lower row is planar imaging of the same patient at the same time. So what you see here is imaged at 1 hour post-injection of the radiopharmaceutical, around 24 hours post-injection of the radiopharmaceutical, 48 and 72 hours. So in this case, the patient got imaged 4 times after administration of lutetium PSMA, and on top of that, the patient underwent SPECT-CT and planar imaging. So you can imagine that takes a lot of time, but I hope you can appreciate how the radiopharmaceutical uptake in the kidneys, here in both kidneys, is being washed out fast. So it gets very transparent here in the right image. But then when you look at the spine metastasis, so the bone lesions here in the individual vertebra, you see how the uptake increases, so it takes a while until lutetium PSMA binds to the tumor site, and then the washout is not as fast as from the kidneys. What you can see in the planar images is the problem of two-dimensional imaging. Very short after administration of the radiopharmaceutical, there's a lot of black radioactivity here. Black means there's a lot of radioactivity, but this is still in the bloodstream of the patient. It's not yet binding to the tumor sites or being excreted by the kidneys. On day 2, it starts binding to the individual lesions in the patient, but you also see how the large or small intestine here is taking up the radioactivity because it's being excreted through the gastrointestinal tract. Now, another example, I was talking about diagnostics, meaning diagnostic imaging and therapy, earlier. I would like to show you one patient example again with lutetium PSMA therapy of prostate cancer. When you look at that animation here, you see a PET image, so you see a little bit higher resolution. You see again how the radiopharmaceutical is binding to the tumor sites and the skeleton, but also the uptake in the normal organs. This is a fluorine 18 scan, which is a very common radioisotope for PET imaging. And then on the right, what you see is the same image of the same patient, but after therapy. So usually there's a few weeks in between the diagnostic imaging and the therapy application, and then a few hours until the first imaging. You can see it's the same pharmaceutical, the PSMA, but now we have lutetium-177, the therapeutic isotope, and we have a different imaging modality, namely SPECT imaging. So from left to right, you can see how the resolution decreases. This is just due to the nature of lutetium-177 SPECT imaging, but you can also appreciate the uptake in the same region to the same extent, and now you might understand that you can use the image here on the right for dosimetry, which you're going to learn in the series of webinars later. I would like to come to our third example. Here we talk about lutetium-177. Again, you see a very, very prominent radionuclide in nuclear medicine. But now we have dotatate. Dotatate is a pharmaceutical for specifically neuroendocrine tumors, a very rare disease, but not less common to be treated in nuclear medicine. What you can see here again is a combination of a patient first undergoing PET diagnostic imaging. That PET image is also being used by the doctors and the physicians to evaluate whether that patient is eligible to receive the treatment. And on the right again you can see the SPECT post-therapy image, in this case of lutetium dotatate. That patient dataset you can download from the University of Michigan, provided by Unidevaraja for the SNMMI dosimetry challenge. So if you would like to explore a little bit more, feel free to download the patient cases and look at it yourself. What you can see here is that that patient suffers from metastasis to the liver, but also to the lymph nodes in the abdomen. And you can see how the SPECT image is confirming the uptake of the pharmaceutical in the same areas of the lesions and of the lymph node metastasis. Important to note is that SPECT imaging is limited in resolution. We talk about 2 to 4 centimeters, for example, while PET imaging can be in a few millimeters. This is why this tumor is not bigger or progressed, it's just the imaging is inferior to PET imaging. This is why it appears bigger. Now coming to another example. So you see it's really a success story. Lutetium PSMA is the most prominent and most hyped radiopharmaceutical right now in the field. This is why nuclear medicine gets so much interest at the moment by radiology, oncology, and patients from all over the world. What you see here on the left is a patient suffering from heavy metastasization. This is end-stage cancer. And you can imagine how every single metastasis in the skeleton here gives the patient tremendous pain. So you could imagine this patient comes in a wheelchair to hospital. And after only 2 cycles of lutetium PSMA treatment, with a total of 12 gigabecquerel of activity, you can see how the patient is responding to therapy and how this large uptake here is already decreasing and how the uptake is only in the normal organs and in the salivary glands. And after 4 cycles of treatment, this is really an exceptional therapeutic response. You see how all the metastases are gone, how this patient is relieved from pain. A few metastases remain, but this is literally from left to right within a few months after only 4 cycles of treatment. Last but not least, unfortunately, there are some patients who do not respond to lutetium PSMA therapy anymore. And we don't understand that right now clinically or from the medical physics standpoint. This is why we need dosimetry. But another treatment which has shown to be very successful is actinium 225 PSMA. So you see the pharmaceutical part is again the same like in all the examples before, but now we have an alpha emitting radioisotope. Alpha emitting means an even higher damage and even more localized. And again, this patient here is having heavy metastasis in the whole abdomen, but also in the skeleton, so soft tissue lesions and bone lesions. Here a big metastasis in the head and neck region as well. After 2 cycles of lutetium PSMA, that patient was progressive, so the disease got worse and worse. The tumors were progressing. But after only 2 cycles of actinium PSMA, that patient responded nicely to therapy, and after 1 more cycle there is an almost complete response. It's not that all patient cases are like that, but there are many, and every single patient is a success. But that does not mean that we cannot do better. A few examples of radiopharmaceuticals, some of them you will hear in the coming and following webinars. Diagnostic ones, F18-FDG. FDG is a glucose analog, so it's being consumed by cells who have a high metabolic activity. You can imagine that any tumor cells is having a high metabolic activity and therefore taking up F18-FDG. But there's also gallium-68 dotatate for neuroendocrine tumors, same with DOTATOC for neuroendocrine tumors, gallium PSMA or F18 PSMA, F18-FET for brain tumors, technetium-99M MAA for example, lung scintigraphy or for the liver radioembolization simulation. You're going to hear about that one later. And there's technetium-99M MAC3, which is for kidney function tests. All of those are being used for diagnostic imaging, not for therapy. On the other hand, there are a few therapeutic examples. Iodine-131 for thyroid diseases, iodine-131 MIBG, yttrium-90 microspheres and holmium microspheres, which you're going to hear about, lutetium dotatate and PSMA. Those are approved, but there's also many more which are being under investigation, such as alpha-emitting dotatate, alpha-emitting PSMA, lutetium-177 CXCR4, and lutetium FAPI therapy. So after all these successful examples without any dosimetry, you might wonder, why do we need it at all? Well, I invite you to take a look at the VISION trial. This is this paper here, and especially at the outcome. It is for prostate cancer patients, and you might really be surprised about what I'm going to show you. So let's have a look at Germany, where we will have approximately 15,000 prostate cancer patients per year receiving lutetium PSMA therapy. If we look at the numbers, and here in the brackets the percentage, that is the numbers reported by the VISION trial. So for complete response after receiving lutetium PSMA therapy, we will have more than 1,300 patients with complete response, which is great. And 41% will have a partial response. Partial response means some lesions are responding, others are not. So this is over 6,000 patients, which is again great, so patients have benefit. While unfortunately 49% have no benefit or only stable disease, which corresponds to more than 7,350 patients. So in terms of efficacy, yes, there is in some more than 7,500 patients, so more than half of the patients having either partial response or complete. But unfortunately, we will have more than 7,000 patients also with no benefit. And looking at side effects and toxicity here on the right, there will be more than 4,000 patients experiencing any drug-related adverse event, and more than 1,200 patients experience a serious drug-related adverse event, and around 1% will actually be dying due to lutetium PSMA therapy, which corresponds to more than 130 patients. And this is not acceptable from the safety standpoint, and we believe that with dosimetry we can do better. Nevertheless, this has to be shown in prospective clinical trials which are randomized. With that, I would like to thank you for your attention. Please reach out if you have any questions.